So, we are going to look at a very interesting common clinical problem. In day in and day out in our practice, we see people with polyarthritis and polyarthralgia. And rheumatoid arthritis is one among those things. So, today let us look at the count. We are going to look at rheumatoid arthritis today, which is a common clinical problem. Okay. What is the definition of rheumatoid arthritis? We are going by the guidelines and the monogram on rheumatoid arthritis by European Society of Rheumatology, European Association of Rheumatology, UVAR. Okay. So we are going to go by that, and these are international standard guidelines. It is a progressive, systemic, autoimmune inflammation. That summarizes the bit. Inflammation, it's an inflammatory disease, not an external inflammation or infection. It is autoimmune inflammation. And it doesn't come and stop or regress. It's a progressive disease. And it is not only limited to the joints, it is a systemic disease. So you will get a short notes. Discuss the non-articular manifestations of rheumatoid arthritis. That means all systemic things you have. Progressive, systemic, autoimmune inflammation. Often aggressive, devastating consequences. Unknown etiology. Maybe infection may trigger the autoimmunity. Smoking is very well linked to rheumatoid arthritis. Smoking somehow influences the autoimmune problem in rheumatoid arthritis, characterized by what is the crux of pathology of rheumatoid, not arthritis. It is synovitis. The lining of the joint is inflamed. It is a systemic synovitis and chronic polyarthritis. With the result, the joint erosions, cartilage damage, bone destruction can occur. Multi-system, extra-articular manifestations also are there. Usually slow and insidious over months. It is not that it will come today and in 3 months it becomes worse. Slow and insidious progression. 20% may have a rapid or acute course. Aggressive management definitely will help in the quality of life of the patient. So the prevalence is around 0.8 to 2.1% in the population. Gender predilection is 3:1, more common in women. Prevalence increases with age. Juvenile rheumatoid arthritis is also there. Children may also be affected. 40 to 60% have severe disease, and it increases the mortality to 3-fold. Median life expectancy is reduced up to 3 to 7 years. There are two people, let us say one with rheumatoid arthritis and other without rheumatoid arthritis of the same age. The life expectancy is reduced due to rheumatoid arthritis. Onset mostly between 30 to 65, 35 to 60 years. Somebody presenting with 70 years around my age with joint pains, unlikely to be. Likewise, very young persons, excluding juvenile, 20 years, 15 years, unlikely to work. The middle group, 35 to 70, are the, and there is a strong association with HLA-DR1, the particular gene 101 and 401 genes are associated with rheumatoid arthritis. It is a class 2 histocompatibility antigen. Histocompatibility antigens are classified as class 1, class 2, class 3, like that. This belongs to the histocompatibility antigen class 2. The exact etiology of rheumatoid arthritis is not known. How serious? What is the economic burden of the disease? So, for example, compare with the standard coronary artery disease, The total cost of coronary artery disease per patient per year is around $9,000, which is roughly around $9,000 is 9 lakhs in our currency. Okay. Now the burden of rheumatoid arthritis is around $6,500. That means it is a very disease with a lot of economic burden too. Okay. Now this you have to understand very clearly. What is this? So an antigen, how it is presented, first of all. A primary exposure to an antigen occurs. This is true for almost every immune mechanism in the body. Primary exposure of the antigen, the phagocytes take the antigen. That is, these are the macrophages. These macrophages go and present the antigen to the T cells. And these T cells are called they stimulate the helper T cells. So here is the antigen. The phagocyte is the one which takes. T cells are not available everywhere. Wherever the T cells are there, the antigen is taken by the phagocyte macrophage and presented to the T cell. Once the T cell receives it, it has got two ways it will deal with it. One, it stimulates the B cells or it stimulates the cytotoxic cells. If it stimulates the B cells, the B cell line will proliferate. B cell proliferation ultimately leads to plasmocytes. The plasmocytes secrete the antibody. Immunoglobulin M to initial antibody, immunoglobulin G later antibody. Always immunoglobulin M is the immediate antibody, immunoglobulin G is the later antibody. And again, this is mediated by helper T cell. Or the B cells, they may keep it in the memory. They may not immediately produce antibodies, and the memory B cells are produced. Memory B cells can go and stimulate the plasmocytes at any time when the antigen is presented at a later stage, and then produce antibody. That is called the secondary antibody response. Primary antibody response to plasmocytes, secondary antibody response to memory B cells. Or the helper T cells may stimulate the cytotoxic T cells. Cytotoxic T cells may have a direct cytotoxic activity, or they may produce memory T cells. These memory T cells and memory B cells produce secondary antibody response and secondary cytotoxic activity. Okay. So the memory T cells, what they will do? They will again stimulate the exposure of the antigen is there. They will again stimulate the memory helper T cells. So it's not that B cells are directly getting the information from the antigen. It is only through the helper T cells. Both the B cells or the T cell series get, there are what are called the helper T cells, cytotoxic T cells, K cells also are there, killer cells. They will attack the cells which are infected and then kill them. They are called the killer cells. Okay. For every presentation, you may understand, I am giving you a lot of pathological, biochemical basis of the disease. Without understanding this, just going into clinical science will not help you to really understand the disease. So, non-specific initiation of the inflammation, non-specific insult to the tissues. Then that results in T cell amplification, memory T cells, memory macrophages, B cells, dendritic cells, cytokine activated synovial synoviocyte, antigen presenting cells. What are the antigen presenting cells now? The macrophage goes to the B cell, transferred to the dendritic cells, then the cytokine activated cells. All will produce B cell stimulation. Once the B cells are stimulated, they secrete the antibody, and the antibodies will have complement activation that leads to cytokines and proteases, synoviocytes, and chondrocytes. Macrophage, synoviocyte, chondrocyte, and osteoclast. These are the various cells that are involved. So this is a very interesting diagram which you need to understand. So the macrophage is the one which is the presenting one. The macrophage, once it presents it and the rheumatoid factor is secreted and anti-CCP is secreted, they form immune complexes. These antibody-antigen complexes is called the immune complex. That immune complex, when it fixes the complement, it through the action of neutrophils and mast cells, it initiates the inflammation. Now, most important point that we need to know as far as treatment is concerned, there are two factors, the cytokines which are involved in this. One is called the tumor necrosis factor alpha, the other is called the interleukin 1. Now, why do I need to know? Tumor necrosis factor alpha antibodies are there, and then interleukin 1 antibodies are there. The treatment involves these newer agents called the biologicals. The treatment of rheumatoid arthritis has changed for the last 10 years, and biological usage has become much commoner and better treatment for the patient. Now, immunology of rheumatoid arthritis. So there are signals from the macrophage to the T helper cell, and these signals are through interleukin 6, interleukin 12, interleukin 15, 18, and TNF-alpha. Some of them are pro-inflammatory, some of them are anti-inflammatory. So ultimate mediation is through the TNF-alpha and interleukin 1. So what is happening is in the body, there are several pro-inflammatory cytokines. There are several anti-inflammatory cytokines. Anti-inflammatory cytokines are IL-10, IL-RA1, soluble TNFR, and then IL-11. These are protective. Not only in this disease, in general, these are anti-inflammatory cytokines. Sometimes you may get a short notes, particularly in your paper 1. Write short notes on cytokines. Then you need to know what are the anti-inflammatory cytokines, what are the pro-inflammatory cytokines. Pro-inflammatory are interleukin 6, interleukin 8, and GM-CSF. What is GM-CSF? Granulocyte macrophage colony stimulating factor. Granulocyte macrophage colony stimulating factor. And these will act, where do these act in rheumatoid arthritis? They go and act on the bone and the cartilage. Because the primary inflammatory site is the synovium. In the synovium, TNF-alpha and interleukin 1 are released, and now their target is not the synovium anymore. They go and attack the bone and the cartilage underlying. Okay. Now you see this diagram. This very clearly, the balance is between pro-inflammatory and the anti-inflammatory. This summarizes what are all the pro-inflammatory, what are all the anti-inflammatory. Anti-inflammatory are IL-4, IL-13, IL-1RA, tumor necrosis factor beta, and IL-10 are protective anti-inflammatory. Whereas tumor necrosis factor alpha, IL-1B, IL-8, IL-6, TNF-gamma, that is the interferon gamma, INF-gamma are all the pro-inflammatory factors. Okay. Now, cytokines are TNF-alpha and chemokines are interleukin 6 and 1. Now I'll ask you one question. What is the difference between a cytokine and a chemokine? Cytokines act only where they are sitting. Like there is a chair. In this chair, there is a cell, that T cell, that produces cytokine. It interacts with all the foreign particles at its own site, in the site only, in the cell only. Whereas chemokines are secreted outside the cell, they circulate all over and damage elsewhere also. You understand? Chemokine also is a cytokine, but it has got the legs to go around, it has got a car. It will take the car from the garage and go and do the damage everywhere. Whereas the fellow cytokine fellow doesn't have transport. He will be there only if somebody comes there, he will. You understand? So always you must know that. When a short note is asked about inflammatory cytokines and chemokines, inflammatory mediators, you should be able to say this is cytokine, this is chemokine, these are pro-inflammatory, these are anti-inflammatory. Take one, for example, rheumatoid arthritis. In addition, there are other growth factors, MMP. MMP is the matrix metalloproteases and vascular endothelial growth. What does it do? They don't do anything. Any inflammation they won't produce. Their job is to proliferate the angiogenesis. So they try to give you extra blood supply to because these fellows are quarreling. No, for them to quarrel, they should food. That food is supplied by this. For the cytokines and the cells to damage that one, they have to multiply. For multiplication, they require food. That food has to be supplied by extra blood. That is the angiogenesis. So MMF and VEGF or pro-inflammatory secondarily by supplying, okay, you fight, but I give you bread. They bread them and then make them fight. So you can control the inflammation by stopping the angiogenesis also. That's also one mechanism. That's why it has to be known. Everything has got a clinical implication. Now, what is the natural course of rheumatoid arthritis? Undifferentiated polyarthritis. When a fellow is in that case, you cannot say whether he is a rheumatoid arthritis patient or any other arthritis. It's an undifferentiated polyarthritis. Okay, the second type is early rheumatoid arthritis or mild disease. And the third step is severe rheumatoid arthritis with deformity. Timeline of function loss in rheumatoid arthritis. How much time it will take? 0 is when the disease started. By 2 years, there is a moderate function loss. By 5 years, severe function loss. That means patient will not be able to do his or her own normal daily act in 5 years. In 10 years, very serious function loss, almost bedridden. That means it is a crippling disease. 25% require surgical treatment also, because there is a role for joint surgeons also in rheumatoid arthritis. So how do I diagnose? ACR criteria, American Society of Rheumatology and European Association of Rheumatology. These two we are following. We are now taking the ACR criteria. ACR is American College of Rheumatology. American College of Rheumatology, a patient to be diagnosed as rheumatoid arthritis, you have to have these following criteria. Just like the Jones criteria for rheumatic fever, you require to fulfill these criteria. Definitely in YOC, if there is a discussion, they will ask you what are the criteria for diagnosis of rheumatoid. If you blast them with this answer, they will keep going. One important thing is early morning stiffness. Ask the patient, as soon as you get up, do you feel that the joints are very stiff and painful, which is a hallmark of rheumatoid. All of us will have it. When you get up for 5 minutes, you feel the stiffness. But this will be for more than 1 hour. People will have, rheumatoid arthritis fellows will have early morning stiffness for more than 1 hour. Arthritis of 3 joint areas out of the possible 28 joints. I will show you the 28 joints in the coming slides. Okay, arthritis of the 3 joint areas or more out of the 28 joints. Suppose somebody is having one pain little here. At least 3 joint areas it should cover. Arthritis of the hand joints. Somebody is having something in the hands. This is definitely going to be rheumatoid. Here, there are, you see, this is called the metacarpus. The metacarpal bone and the phalangeal bone, MCP joint. MCP joint is this one. What I am moving now. This is the MCP joint. This one is called the interphalangeal joint, proximal interphalangeal joint. This last one is called the distal interphalangeal joint or terminal interphalangeal joint. The most important thing that you need to know is rheumatoid arthritis involves metacarpophalangeal joints and proximal interphalangeal joints. MCP, PIP. TIP, terminal interphalangeal, not spared. Tips are spared. TIPs are spared. MCP and the PIP, proximal, or even carpal bones and wrist also may involve the radio ulnar joint or the joint between the radius and the carpal bones. It can affect. Symmetric swelling. Another thing is the disease is symmetric. There will be one side. It is not usually unilateral. It is bilateral disease. And if the wrist joint on this side is involved, there will be wrist joint on the other side. Symmetric involvement of both sides. Serum rheumatoid factor, RF factor, an antibody to immunoglobulin G is positive. Rheumatoid nodules in the advanced stages, radiographic changes are also late to occur. So what I should have? Early morning stiffness of more than 1 hour, arthritis of more than 3 joint areas, Tips and pips and risks, MCPs and tips are involved, risks are involved. Tip is not involved. Symmetric involvement, both the sides are a factor. Positive, rheumatoid, nodules, X-ray changes. First four criteria, not for 1 or 2 days, at least 6 weeks. First four criteria, if they are there for more than 6 weeks, the patient qualifies for rheumatoid arthritis. What are the 28 joints? Sorry. Yeah. What is the typical involved? Wrist joints, MCP joints are very commonly involved. Index and middle metacarpophalangeal joints are affected. Proximal interphalangeal joints, PIPs, metacarpophalangeal joints, metatarsophalangeal joints, elbows, shoulders. Knees, ankles, and hips and lumbosacral area are not involved. Somebody comes with knee pain, very unlikely to be rheumatoid. Knees, ankles, and hip joints and LS spine is in general, it is an axial skeleton disease. It is not, it is an appendicular skeleton disease. It is not an axial skeleton disease. Axial skeleton is the spine, appendicular skeleton is. It is a disease of the appendicular skeleton, whereas ankylosing spondylitis is a disease of the axial skeleton. Here, spine is totally spared, except the Atlanta occipital joint. Atlanta occipital joint can be affected. There can be subluxation of the Atlanta occipital joint, and it can lead to spinal compression. I have one patient with me right now. She's being treated in this hospital. She had rheumatoid arthritis in the C1, C2, Atlanta axial subluxation, and the odontoid process is totally dissolved. Due to subluxation, there is a myelomalacia of the cord, and she is having paraparesis with little weakness in the arm. It's almost wheelchair bound. This is a case of Atlanta axial subluxation. We diagnosed here on. Terminal interphalangeal joints are not usually involved. Okay. Now, what are the 28 joints I should look for? MCP is 4, PIP is 4, 5 plus 5. So 5 plus 5, 10 here. Metacarpophalangeal joints, proximal interphalangeal joints of this. Okay. 5 plus 5, 10. Wrist, 11. Elbow, 12. Shoulder, 13. Okay. How many we have got? 4 plus 4, 8 plus 2, 10. 10 plus 3, 13. 13 and 16. And finally, the knee joints you have to look. Without hand, isolated lower limb knee joint involvement will not happen. So 13 on one side plus the one in the knee, you have 14 multiplied by two sides is 28. So what I will do? When the patient comes, I'm having joints, pain here, pain here. First I'll ask, do you have early morning? And then before that, how long are your symptoms? 2 days, go. Take medicine and come back. 6 weeks or more. Yeah, come. Now sit with me. Do you have the stiffness? Yes. Is there involvement of more than 3 joint areas out of the 28? Then, is there any swelling? Is it bilateral? The third question. The fourth question is, what are the joints? Is the tips involved? No. Are the hips and ankles and spine involved? Not rheumatoid. I have excluded. Then, come and examine the joint. You have to examine for 2 things. One is tenderness, the other is swelling. You have to score for tenderness and swelling. And you have this chart you can keep on the table and you can tick the joint which is affected under the tenderness, under the swelling. Then you will know how many are affected. This chart will be useful for follow-up. Once you treat the patient, where swelling is decreasing, where the pain is decreasing, tenderness is decreasing, those things you can note it in the follow-up. Okay. Now, this is a very important scoring called the DAS scoring, Disease Activity Score 28. This has to be calculated in every patient of rheumatoid arthritis. Calculating using the formula that includes counts for tender and swollen joints. How many are possible? 28 into 2. 28 tendernesses, 28 swellings can be there total. So 52 is the upper limit of the score. So in that you note down. Then general health of the patient. You ask the patient, if you educated patient, give him a scale of 0 to 1. So if I give you a scale of 0 to 1, 0 means useless life, 100 means perfect. So let the patient say, I'm 70% better, 60% better, 55% better, whatever. Then you measure the CRP or ESR. That's all is required. And there is a small formula, EULAR, European League Against Rheumatism. That's what I'm telling. EULAR formula is there. Just punch this in that in your Medcal. What is that? How many are swollen? How many are tender? And what is the patient's perception? And what is the ESR like? Then you get a summary score of more than 5.5, high disease activity, 5.1 to 3.2, moderate activity, 3.2, low disease activity, 2.6 or less, being in remission. Response to treatment means patient should come at least 1.2 points below the original level. Less than 6.6 means he or she is not improving. This is called the disease activity score. Very simple. You don't require a very complicated investigation. What all we are asking is just examine the patient. Tenderness and swelling you note in the 28 areas. 28 areas I have mapped you and showed. And I ask the patient his feeling about himself or herself and then get an ESR done. This information you put it in that calculator and it will give you this. It's not difficult. Doesn't require big investigations like PET scans or MRIs or anything. Very simple clinical diagnosis. You must have suspicion. Then only. Class 1, complete ability to perform daily activity, self-care, vocational, avocation. Vocational means job related. Avocational. Avocational means sports, relaxation and other. Avocation. Okay. 2, Class 2, ability to perform usual care and whole vocational activities, limited in sports and avocational activities. Class 3, difficulty in performing self-care like brushing teeth, washing or dressing, but limited vocational or avocational activity. Class 4, limited to perform even the usual self-care activity, vocational and avocational activity is not possible. Now, this slide is very important. What are the extra-articular manifestations from rheumatoid? If you have this slide in mind, you can just quickly write out and come. Musculoskeletal wasting, tenosynovitis, bursitis, osteoporosis, rheumatoid nodules, vasculitis, arteritis, pericarditis, myocarditis, systemic illness. Special features, episcleritis, scleromalacia, pleural effusions, nodules, cervical cord compression due to C1, C2 subluxation, mononeuritis, carpal tunnel syndrome, Feltis syndrome, Kaplan syndrome. In Feltis syndrome, there will be splenomegaly and anemia. Anemia, splenomegaly, rheumatoid arthritis, Feltis. Okay. So systemic involvement and special features. If you are asked about I'm sure this will be a short notes, one day or other, extra-articular manifestations, so rheumatoid arthritis. Discuss inflammatory mediators. That could be also a short. Now I'm going to show pictures here. You can see these are the rheumatoid nodules there. You look for the rheumatoid nodules in the olecranon process around that one. And also you see the swelling of the proximal interphalangeal joints and the metacarpophalangeal joints. And examination should be with both the hands. And for tenderness, you have to examine each of those joints out of the 28 with palpate them and look for the swelling. Two things you have to note, tenderness and swelling. Okay. Now I'm going to show some grotesque pictures of rheumatoid arthritis. So you see here, the rheumatoid arthritis late stage, botonary deformity, ulnar deviation of the metacarpophalangeal joint, swan neck deformities. Why I am showing this picture? Not for you to diagnose looking at these pictures. You should not allow any patient to go into this stage. The idea of you're a good physician, you rarely will make your patient be a photograph like this. Okay. So it's to tell you that we have to intervene early and then prevent that. This is called the swan neck deformity, like this. This will be bent here, and this will be hyperextension at this joint and flexion at the terminal interface. This is not involved, but because the joint is involved, the tendon is pulled, and there will be this. In claw hand, it will be like this. Claw hand of leprosy, all the joints, PIPs, TIPs, carpomata, everything is flexed. Whereas here, swan neck, only tips are flexed. Okay? Claw hand is as if somebody is like a lion. Yeah. As you see in case of leprosy. Okay. Now, you see again the abundance, the nodules there now with the ulnar deviation of the ulnar deviation is very common rather than radial deviation. Extreme swelling of the carpometacarpal joints, and you see the X-ray. This is the normal X-ray on the left side. On the right side, you see complete erosion, and then the outward deviation, lateral deviation. We don't call ulnar or radial here because this is foot, and we don't call tibular and fibular deviation. We call it as lateral and medial. Lateral deviation of the great toe joint, that is the tarso-metatarsal. Here also ulnar deviation of the carpometacarpal joints and destruction of the joint cartilage, as you can very well see on the X-ray. Do not wait for those changes to come. So it's an extreme form of rheumatoid arthritis with severe rheumatoid nodules all over, and also the lower limb also is affected. And you see the X-ray picture of rheumatoid arthritis. So always what you do is when the patient is suspicious, ask them to take an X-ray of the hand. What you have to ask? Don't ask for epilateral just like you ask them. Ask them to, as though on the X-ray plate, they have to keep the hand like not this way. So the palm touching the X-ray plate, you take that. That's the X-ray you have to order. Okay. Then you can see a normal X-ray on the left side, and the rheumatoid arthritis. X-ray with the gross destruction on the right hand side. Okay. Now, so this is the atlanto-occipital subluxation. Actually, this odontoid process should be here. It has subluxated to that side. So backward, this is the spinal canal here. It presses on the spinal cord and then produces myelomalacia and para-quadriparesis. So blood parameters, what do I do? How do I evaluate it? What are the things which I can look in the blood? CRP is a very good single important marker. If the CRP is normal, it is unlikely to be rheumatoid. It excludes rheumatoid. But if the CRP is elevated, it cannot confirm. There are several conditions in which CRP is elevated. Then you require, don't depend on ESR. So many confounders are there for ESR, including anemia. So we don't look at ESR, look at the CRP and ask for ceruloplasmin. Ceruloplasmin levels are increased in case of rheumatoid arthritis. Whereas in case of copper storage disease, they are decreased in Wilson's disease. Ceruloplasmin is an acute phase reactant. Haptoglobin also is acute phase reactant. They are similar to CRP. You can do CRP, ceruloplasmin, hepatoglobin, leukocytosis will be there, neutrophilia will be there, normocytic normochromic anemia, chronic disease anemia will be there, platelets will be increased in number, thrombocytosis. Okay. Now, synovial fluid aspiration not required. Whereas in case of crystal arthritis, you require synovial fluid aspiration to confirm it, gout from pseudo-gout and other things. In septic arthritis, you require synovial aspiration to find out what is the organism. Here, you don't require synovial aspiration. It is only required in case you want to include other diseases. If at all you do a synovial aspirate, it looks like turbid fluid, increased protein, decreased glucose, WBC are more, PMMs are very much increased, complement C3 and C4 are markedly increased in the joint fluid. Why? Because this is an antigen-antibody reaction involving the complement there. And the joint fluid will have large quantities of C3 and C4 complement. Okay? Rheumatoid factor. What is rheumatoid factor? Keep on ordering it. Rheumatoid factor, rheumatoid. You must know what it is. developed by a person called Eric Rosewaller, and that's why it is called Rosewaller test. 1937, almost around 95 years back, 90 years back. It's an agglutinating antibody. Latest particle agglutination assay is used, and it is an type specific antibody. Antibodies to the Fc portion of the immunoglobulin. This is to our own immunoglobulin. The antibody is manufactured. That's why it is called autoimmune disease. What is Fc portion and FAB portion? I will show you in the subsequent slide. 5% of normal persons also rheumatoid factor may be positive. That means there are false positives with this one. And it is positive only in 70 to 80%. Remaining 20-30% may not have. That means a lot of false positives, low sensitivity, lot of false negatives are there. It is not a screening or diagnostic tool. It is more a prognostic tool. A rheumatoid factor by itself is not a diagnostic tool or a screening tool. It is more a prognostic tool. It is negative in 30% of cases. That is called the seronegative rheumatoid arthritis. Rheumatoid factor is commonly seen in the other conditions. So before that, I'm going to show you what is the Fc portion. This portion of the Y-shaped is the antibody. The immunoglobulin G antibody is like this, like Y-shaped. This portion, the tail-like portion, is the constant portion. That's why it's called Fc, fragment constant. Okay, these two are called the antibody portions, FAB portion. In the FAB portion, the lower part is constant and the upper part is variable. C is constant, V is variable. There are two types of chain. The red one is the heavy chain and the blue one is the light chain. Antibody area, FAB has light chains and heavy chains, variable portion and fixed portion, and a constant portion and variable. In the variable, you have heavy and light, and here is the antigen binding site. The rheumatoid antigen is bound here and produces an antigen-antibody complex, and the complement is fixed. This is the FAB portion, FC portion, fragment constant, fragment variable, FAB again variable. Now, positive rheumatoid factor is seen in what are the conditions you see rheumatoid factor positive other than rheumatoid arthritis? Of course, rheumatoid arthritis, 70%, advanced rheumatoid arthritis, 100%, Sjogren's syndrome, 90%, SLE, 30%, acute bacterial endocarditis, SABE, 40%, tuberculosis, 15%, elderly people, 20%, normal, healthy individuals, 5%. Somebody comes with a report. Sir, I did a blood test on my own, gave the blood to high-tech lab or Thyrocare. They gave me rheumatoid factor positive. You can never treat a lab report. Don't treat the lab report. Treat the patient. Come here, show me your hand. Ask all the questions. No rheumatoid arthritis. Go. 5% of the individuals will have like that. And advise him not to test on his own next time. Come here, I'll tell you what test you have to do. It is not like asking asking for a brew coffee on your own or a Mysore Pak in the sweet shop. Can't order test like that. It should be ordered by me. And don't interpret tests also. Two things. Don't order test, don't interpret test. This you have to tell your patient, of course, in a polite line. Okay. Anti-CCP, the newer antibody is very important. Cyclic citrullinated peptide or anti-CCP antibody is a better test because sensitivity is similar, but specificity is very high. Specificity means if anti-CCP is positive, it is a case of rheumatoid arthritis. It confirms the disease. In early polyarthritis, anti-CCP is useful for diagnosis, and rheumatoid factor is useful for prognosis. Anti-CCP is associated, somebody has got anti-CCP, the disease is more severe, as it spells a poor prognosis and rapid progression, and may be positive in asymptomatic patients years before the rheumatoid arthritis. That is the beauty of antigens. Now, how do I use these two tests? I can combine both for the advantage of patients. So if I use RF alone, rheumatoid factor, 75%. Sensitivity, specificity, 60%. So anti-CCP alone, 96% specificity, very good to confirm the disease, but it cannot exclude the disease. Sensitivity is not there. If it is negative, I cannot say. Suppose I use both, then my specificity increases, my sensitivity also increases. So order, you have doubt, order both anti-CCP and RAF and improve the sensitivity and specificity. Now, what is the differential diagnosis of rheumatoid arthritis? Any connective tissue disease, scleroderma, SLE, fibromyalgia, palindromic rheumatism. What is palindromic rheumatism? It's a short note. Actually, the batch, 3 batches before, the question was palindromic rheumatism. Palindrome is what? What is a palindrome? Read from this side or that side, it will come. So in English, several letters, the words are there. So so palindromic rheumatism means today it appears here, tomorrow it goes here, next week again it comes here, again it goes, shifts between the joints. Palindromic rheumatism is initially it will pick up 4 or 5 joints. It keeps on rotating between these joints. So what happened last time I was very painful here now. Now I am very happy. But the same thing I stuck here now. And again after 1 month he comes, no sir, this has gone. Again this has come. This is palindrome. Okay. Infectious endocarditis, acute rheumatic fever, polyarticular gout, polymyalgia rheumatica, sarcoidosis, hemochromatosis, seronegative spondyloarthropathies, reactive arthritis, particularly Rheumatoid disease, inflammatory bowel disease arthritis, psoriatic arthritis, Still's disease, thyroid disease, and viral arthritis are the different. In fact, every arthritis is a differential diagnosis. And to say that rheumatoid arthritis has got some specific criteria, specific clinical presentation, specific course, and the 2 important tests. Okay, apart from CR. Now, one common thing is it rheumatoid arthritis or osteoarthritis? How I differentiate between them? Pathology, osteoarthritis is degenerative, rheumatoid arthritis is autoimmune. Patient will not say it is degenerative or autoimmune. You only have to say that age, any age can affect rheumatoid arthritis, usually 35 to 60. Osteoarthritis, 30-year fellow, 25-year, 40-year fellow, you need not think about osteoarthritis. It is as the age advances, the disease of the older people, whereas this is the middle age here. Joints involved, small joints, MCP, PIP. There, knee joint, shoulder joint, ankle joint, hip joint, large joints, PIP, TIP, tip salad. Okay, spine never involved in rheumatoid arthritis except C1, C2, whereas lumbosacral arthritis is the commonest osteoarthritis. Extra-articular manifestations, very little in osteoarthritis. There are so many multi-system diseases. This one, course, rapidly progressive, that is slowly progressive, disability, rheumatoid arthritis, highly disabling, osteoarthritis may be mild to moderate. So this table is very important, differential diagnosis between rheumatoid arthritis and osteoarthritis. This is a simple picture. The green color one is both hands or feet. Involvement is highest, either hands or feet. Hands and feet, very less involvement. Feet involvement and then hands involvement should be looked for. Metatarsal joints, tarsometatarsal joints, carpometacarpal joints, metacarpophalangeal joints, proximal interphalangeal joints. Now, rheumatoid arthritis predictors of prognosis. A common question patient comes, sir, you say my rheumatoid factor is positive, anti-CCP is positive, you tell me that you have a very chronic disease, rheumatoid arthritis, that is almost a progressive lifelong disease. What is my prognosis? You ask and you have to know. More than 20 inflamed joints, very poor. 28 like 20 inward. That means very poor prognosis. Markedly elevated ESR, more than 100. Radiographic evidence already there. Nodules are there. High titers of CRP area factor and HCCP, high class functional disability class 1, 2, 3, 4. The patient presented with class 4 disability or class 3, persistent inflammation, comorbidities like diabetes and obesity and other things, advanced age rheumatoid arthritis, low socioeconomic status, low educational level, and those who are HLA positive. The HLA positive, you can do the HLA test for prognostication and not for diagnosis. So if the patient comes with more number of joints, markedly elevated ESR, CRP, RA factor, CCP, radiological evidence of rheumatoid arthritis, rheumatoid nodules are there, high class functional disability is there, other comorbidities are there, inflammation is persisting, advanced age, and then HLA positive. So 40 to 85% of the rheumatoid arthritis patients unable to work after 8 to 10 years. So today I have diagnosed in a 30-year-old fellow or 40-year-old lady rheumatoid arthritis. In 10 years, she will not be able to work. 85% of them. So see, that is the disabling disease. You have to aggressively treat these patients. So what are the complications of rheumatoid arthritis? Carpal tunnel syndrome, Becker's cyst, subcutaneous nodules, systemic vasculitis, Sjogren's, peripheral neuropathy, cardiopulmonary involvement, Pelti's syndrome, anemia, splenomegaly, rheumatoid arthritis, lymphomas can occur more frequently in rheumatoid arthritis. Risk of infection due to disease and treatment. So then what are my goals of therapy? The goals of therapy are relieve the pain, reduce the inflammation, protect the joint, maintain the functionality, control the systemic effects, slow the progression of the disease, increase the quality. Quality is quality of non-pharmacological management. Rest. And don't ask them to go and do physiotherapy. It will become no. This is one condition where you should not do any for the inflamed joints, any physiotherapy, other than routine walking. Exercise, flexibility and stretchings can be done, muscle conditioning, cardiovascular and aerobic exercise. Okay, not weightlifting exercises or any other joint related exercise. Diet, weight management, physical and occupational therapy. Therapeutic window of opportunity. Erosive changes occur early in the disease. Even a brief delay in therapy can have a significant impact on the disease. That means you diagnose today, you ignore, put them on analgesics and leave. Don't give the DMRDs. You are in trouble and patient is in trouble. What is DMARD? Disease modifying drugs. Drugs which modify the activity of the disease. What are the disease modifying drugs? Most important one is methotrexate or combination of other DMARD. Bridge the gap initially with NSAIDs and glucocorticoids because my disease modifying therapy takes time to 1 to 2 months to take over. I start methotrexate today. For it to have an effect, it takes 2 months. During that time, I use good NSAIDs or even a steroid also. I can use short-term steroids to bridge. This is called the bridge therapy. Biologics only in refractory cases. Biologics you should not use. Only those who are specialized in autoimmune diseases, they should use the biologics. But the cost is very high. Surgical treatment in selected cases. So all the same, you have to put the patient on disease modifying therapy. So what will happen? 25% of the patients will have 25% of patients will have surgical requirement at some stage or the other. So what are the medical managements I have? NSAIDs, COX-1 and 2 inhibitors. I don't want to use COX-1 inhibitors because they produce a lot of gastric symptoms. Better put them on etoricoxib or then tericoxib or helicin. These are the COX-2 inhibitors. Glucocorticoids, prednisolone can be used, methylprednisolone can be used. And IAS means intra-articular steroids can be used to start with. DMRDs, we have 4 DMRDs available, methotrexate, sulfasalazine, hydroxychloroquine, and chloroquine. Out of the 4, the king is methotrexate. All others are support drugs. You can use a combination of 2 DMRDs. Immunosuppressive drugs like azathioprine, lefulanamide, and then cyclosporine. Cytotoxic drugs like cyclophosphamide, biologics, human necrosis factor alpha antibodies, IL-1 antagonists are there. Older drugs, gold salts and penicillamine are not used nowadays very much. So what is my armamentarium of drug? NSAIDs, particularly COX-2, steroids, either local, intraarticular, or prednisolone and methylprednisolone. DMRD must be started. No delay in DMRD. Methotrexate, sulfasalazine, hydroxychloroquine, chloroquine. Among the four, chloroquine is not commonly used. Hydroxychloroquine. It's available as HCQ, hydroxychloroquine. And then immunosuppressive drugs, azathioprine, lefulanamide, and cyclosporine, cyclophosphamide, biologics. Just to know about them, we are not going to do much discussion on that. NSAIDs, COX-1 and COX-2. COX-1 have got an action on the renal and GI also. Whereas COX-2, they avoid the kidney, they avoid the GI tract. They are safer drugs. So COX-2 inducible pathway NSAIDs are better. Celecoxib, etocoxib, meloxicam, these are the ones. Because these are better drugs. Non-selective drugs are NSAID class of drugs, non-selective and selective. Non-selective, ibuprofen, ketoprofen, diclofenac, aceclofenac, piroxicam, lornaxicam, naproxen, indomethacin. These are the NSAIDs which are not selective to the joint. NSAIDs used as analgesics are ketorolac and aspirin, selective COX-2, celecoxib, etocoxib. Oh, these are the students. Oh, sit down. Celecoxib, heterocoxib, meloxicam. We are discussing rheumatoid arthritis. I will share this presentation and video to you in the group. If you join the group, you can also look at that. Analgesics, very severe pain, you can use tramadol or paracetamol. Now, pros and cons of NSAID therapy. If I put a patient of rheumatoid arthritis on NSAID treatment, what are the things I should consider? Pros is effective control of pain and inflammation is essential. You have to keep the quality of life. Effective reduction in the swelling is important, and this improves mobility, flexibility, range of motion. It improves the quality. Quality is quality of life. Relatively low cost. Biologicals are expensive. Methotrexate is tricky. So NSAIDs have a good role to play. Cons are they are not disease modifying. They don't change the course of the disease. There is a GI toxicity problem may be there, renal complications, irreversible renal insufficiency, renal papillary necrosis can occur, hepatic dysfunction, CNS. So, NSAIDs are double-edged sword. You have to use them when to use, and as long as you need, then come out. Once the disease-modifying agent takes care, then NSAIDs role will become less. Pros and cons of corticosteroid therapy. They are anti-inflammatory, immunosuppressive. This is an autoimmune disease. It is good to suppress. But there can be a bridge gap between the initiation and the DMRD because disease-modifying treatment with methotrexate or lefulanamide or sulfasalazine or hydroxychloroquine will take time to act. If I start the disease-modifying agent today, after 2 to 3 months only, the peak effect will come. During that time, patient will have pain. So you have to use the NSAIDs. Intra-articular corticosteroids can be used to individual joint flares. Cons are they are not conclusively, they affect the disease progression. Tapering and discontinuation and often a use of often is unsuccessful. Low dose results in skin thinning and ecchymosis and Cushingoid appearance. Significant steroid-induced osteopenia. Most important thing you should know about methotrexate. Methotrexate is given as 10 to 30 milligrams. You see always the prescription, go and verify. In your ward, they'll put on 5 milligrams of methotrexate. Useless. You should not start on such low dose. The minimum dose is 10 milligrams. How? Weekly once, not every day. Because the drug will be there in the metabolism 1 week. So, 5 milligrams BID or 10 milligrams OD on every Sunday or Thursday, one particular day, orally. If you want to quickly, methotrexate is available as IM and SC also. And the DHF, that is dihydrofolate reductase inhibitor. How does it act? It inhibits the enzyme dihydrofolate reductase. Clinical improvement takes place 1 to 2 months. Nausea, diarrhea, mouth ulcers, rash, loss of hair, abnormal LFT should be watched for. So what I will do? I will ask the patient to look for any mouth ulcers, any diarrhea, you should tell, any rash and alopecia, and always every month you should do LFT and CBC. CBC and LFT must be done for every patient who is on methotrexate. Very rare low complications are leukopenia, thrombocytopenia, pneumonitis, sepsis, liver disease, EBV, Epstein-Barr virus related lymphoma. What you have to order? Creatinine, CBC, LFT monthly for 6 months. Then every 2 months, repeat AST and ALT in every 2 to 4 weeks. If initially elevated, adjust the dose. Rapid onset 6 to 10 weeks tends to produce more sustained results, can be used when cause of polyarthritis. Uncertain also. Suppose you don't know, you are not in a doubt which is rheumatoid arthritis or not. Nothing wrong in starting method. Because if it is rheumatoid arthritis, you have acted early and prevents it. Later on the diet, it will unfold. Okay, often combined with other DMRDs like lefulanamide, sulfasalazine, and hydroxychloroquine. Now, there is a paradigm shift in the understanding of current treatment of. Okay, current treatment, traditional DMERDs. DMERD means disease-modifying anti-rheumatic drugs. Disease-modifying anti-rheumatoid drugs. Okay. Early paradigm, evolving paradigm is early and aggressive treatment. Whenever you have a suspicion, start at least 20 milligrams, not 5 milligrams. Many physicians I have seen, they start at 5 milligrams once a week, which is useless. They are neither giving or not giving. Supposing I want to move the table, if I use one finger and move it, will it move? And people will say, yeah, he's trying to move. Same thing with clinical treatment. Supposing I bring an elephant and ask it to move, what will happen? It will crush. So it should not be too much. So a clinician should be very careful, giving the right dose at the right time for the right duration and not go lesser or more. Okay. Put a little bit of brew powder. Coffee is tasteless. 5 spoons of brew powder, useless coffee. So adequate only, anything adequate only, you have to do it. Okay. Now, biological should be considered and a combination should be considered. Okay. This is today's paradigm. New paradigm is early and aggressive treatment. This chart summarizes the entire show. Okay. Go through this chart very slowly. One thing is diagnosis of rheumatoid arthritis considered risk factors for disability and erosion, rheumatoid factor positive, anti-CCP antibodies, multiple swollen joints, elevated acute phase reactants like ESR, ceruloplasmin, and then haptoglobin. D4 count is increased, erosions on the X-ray, disability. None of them are there. None of these things are there. Put them on coxib, or etacoxib, or celecoxib, or meloxicam, hydroxychloroquine, with or without low-dose glucocorticoid. Patient responds to continue them. Suppose one of these things are there, like anti-CCP positive, rheumatoid factor positive, multiple swollen joints are there, erosion is there on the X-ray patient. Already having this. She qualifies for an early aggressive treatment. What is early aggressive treatment? I give full dose of methotrexate in combination with sulfasalazine or lefulanamide. Methotrexate with or without hydrochloroquine or sulfasalazine with low-dose glucocorticoid is a powerful treatment. How long? Immediately we have to stop. Whereas the other group, we have not given him methotrexate or disease-modifying agent. Why? There are none of these factors. So we have not considered giving DMERD and then gave these things and waited for 12 weeks. If it is persisting, then he is qualifying for method. If it doesn't have those risk factors, those which are listed here, then I don't require to give method. But wait for 12 weeks, symptoms not regressing, and suspect rheumatoid arthritis and go in this line. Once you give, what will happen? Responders. People have responded, continue. Okay. Monitor. What I should monitor? I should monitor LFT, TBC, creatinine. You should not forget. Okay. Partial response is there. Add leflunomide or TNF blocker. TNF blocker is expensive. Our patients cannot afford. Not available in all the centers. Leflunomide is available. You give him leflunomide. Patient could not tolerate leflunomide or TNF blocker or methotrexate. Toxicity is there. Switch. Stop methotrexate and give leflunomide and TNF. Okay. Non-responder. So non-responder, partial responder, responded but patient had toxicity, or non-responder, add leflunomide or switch to leflunomide or TNF. Then they responded, non-responded. If they responded, continue that. Non-responded, you have to use the monoclonal antibodies. What are they? Abatacept, rituximab, cyclosporine. That is a terminal. So this is the flow chart of how I diagnose and treat rheumatoid. One slide and explain everything about treatment. This is more about the denosumab and the abatacept. So I'm not going to discuss too much on this because biologicals are not in the purview of an internal medicine. But nonetheless, you should know. Anakinra is there, human necrosis factor blockers are there, and then tocilizumab. This tocilizumab has been used left and right in your COVID time. So you should have known tocilizumab. You give tocilizumab. It is an anti-inflammatory interleukin 6 antagonist, IL-6 antagonist. So this slide I'm skipping. But anyway, you can see in the... So now you see the lowest is patient education, simple analysis. That is the base. Then physical therapy, occupational therapy, orthopedic surgery. Then from simple analgesic, intra-articular steroids, iodosteroids, flares and dextrose, salicylates, non-acetylated salicylates, and NSAIDs. Low-dose steroids, then comes the leflunomide, methotrexate, hydroxychloroquine, sulfasalazine combination. Then go for azathioprine, biologicals, dipenicillamine, cyclosporine, higher cases, and finally the experimental drugs. Okay. What are the biologicals available? There are 4 classes of biologicals: TNF-alpha, adalimumab, etanercept, infliximab. Any one of them can be chosen. Interleukin-1 antagonist, anakinra, and suppressors of T-cell activation, abatacept, anti-B monoclonal antibody is the rituximab. So this slide also is about various biologicals, how much time they will take, and how long you will use, route and doses. I am just skipping time because I don't want another lecture for this. Relative contraindications of biologicals: active hepatitis B infection you should not use, multiple sclerosis in patients with optic neuritis, active serious infections, chronic or recurrent infections, current neoplasia, history of tuberculosis or evidence of cough, congestive heart failure. These are relative contraindications, not absolute. The contraindication for methotrexate is pregnancy and lactation. You should not use methotrexate during pregnancy because it's a dihydrofolate reductase inhibitor. Dihydrofolate is the most important vitamin. Folate is the most important vitamin for organogenesis. And organogenesis will be impaired, maturation will not take place. Dihydrofolate reductase inhibitor should not be used in pregnancy, also in lactation. Other than that, safety use that. Safety considerations of biologicals: serious infections, opportunity infections, lymphomas, demyelination, administration restrictions, CHF, fatigue, and vaccination also is going to come. Then when you become senior physicians, probably there will be a vaccination against autoimmune diseases. Rheumatoid arthritis will be the forerunner among vaccines. Okay, that is the thank you all for that. Stop here.